Welcome to Ask the Expert on WMTR 1250 AM, a Beasley Media Group station, streaming live on WMTRAM.com and TalkStreamLive.com. I'm Jessie Frees. Julie Briggs and I host the award-winning Ask the Expert and Your New Jersey Connection, the longest-running radio shows on the station and in the state of New Jersey. March is Colon Cancer Awareness Month. Everyone dreads the word cancer. In the United States, we were all at risk of colon and rectal cancer. Colon cancer is one of the leading causes of cancer deaths, and one is more likely to get the disease if they are over 50. Colon cancer is one of the most treatable cancers if you catch it early. What are the risk factors and what can you do to reduce your risk? What are the differences between colon and rectal cancer, and who is at risk? At what age should one get a colonoscopy and how often during their lifetime? And joining me this morning on Ask the Expert, Dr. Andrew Boxer, a leading MD, gastroenterologist, board certified in internal medicine and gastroenterology, a graduate of Robert Wood Johnson Medical School and member of Alpha Omega Alpha National Medical Honor Society. He is a fellow of gastroenterology, New York University Medical Center, and internal medicine, Mount Sinai Hospital. Dr. Boxer is a partner in Gastroenterology Associates of New Jersey. As assistant professor of medicine, he has won numerous awards and honors, a sought-after lecturer, and he has published many articles. And it's a pleasure to have you join us this morning, Dr. Andrew Boxer.
Great, thank you. Thank you for having me on today.
Oh, it's our pleasure. We are all at risk for colon and rectal cancer, which is, as we said, the second most common cause of death from cancer. What causes colon cancer, Dr. Boxer?
That's an absolutely excellent question. So there's many reasons why patients might get colorectal cancer. So some of them certainly can be preventable. So smoking is a leading cause of colorectal cancer. And some of them you can't really affect yourself. You can't really prevent. So certainly genetic. Some people have genetic predisposition to colorectal cancer. And then there's most of the people in the middle where there's really kind of nothing causing it. Colorectal cancer could be what we call sporadic cancer, kind of just random occurrences with changes of DNA in your colon could cause polyps. Polyps are small little growths, and when they're there, they could grow and grow and grow into a cancer. And there's really kind of nothing you could do to modify that. There's nothing you could do to really cause that or to kind of reduce that yourself.
And is it hereditary?
So there can be. So most colon cancer is sporadic. So over 90% of most colon cancers are sporadic. Probably less than 10% can have a hereditary genetic cause. Like you said, colorectal cancer is very, very common. So this year in America, over 150,000 Americans are going to be diagnosed with colorectal cancer. And it's the second most common cause of cancer death. So it's a very, very common cancer out there.
What causes a person to develop polyps, and when should they be taken out? And are they a forerunner of colon or rectal cancer?
Yeah, absolutely. So kind of that's a hard question to kind of know. So what we need to do, kind of the thing to know is patients need a colonoscopy. Essentially, the only way to prevent colon cancer is a colonoscopy. That's the only thing out there. So what we need to do is we would actually need to go, a gastroenterologist would need to go and take a look through the colon. What a colonoscopy is we give you a big laxative. It's going to give you diarrhea. It's going to clean you out so we can see inside. And then we give you sedation, anesthesia, take a look through the colon with the camera, and we look for these polyps. You never know which polyp is going to be precancerous until you actually go and remove it. So it's standard of care to actually go and kind of remove all the polyps. We send them to a lab to get a biopsy done, and then we would find out what type of polyp it is. But kind of the standard is kind of we're overcautious. If we see something, we go ahead and remove it to dramatically reduce the risk of cancer.
And what age should one be to start with colonoscopies for cancer?
So men and women are both at risk. That's a common misconception that a lot of times kind of women tell me, oh, it's the men that are at risk, and the men tell me, oh, it's the women who are at risk. But both men and women are at risk. The guidelines about a year ago used to say age 50, we start for everybody. But the American Cancer Society last year said that risk, particularly in young patients, so young onset colorectal cancer is on the rise. So the guidelines say age 45 for everybody. If there's a risk factor, so if you have a first degree relative, you want to go age 40 or 10 years before that family member was diagnosed, whichever is earlier.
Right.
And that's for preventative reasons. If there's something going on, so for diagnostic reasons, we could do it at any age. So if someone's having bleeding, weight loss, abdominal pain, chronic diarrhea, or something concerning, we would do it kind of as soon as those symptoms occur.
Let's go over some of the symptoms for colon cancer, doctor.
Yeah, of course. So colon cancer is unfortunately one of these cancers that the symptoms don't start until it's very late. So when we talk about cancer, we talk about the different stages. So essentially stage 1 through 4, where 4 is kind of a widely metastatic or widely spread disease. And that's when patients start really developing symptoms: bloating, weight loss, severe constipation, blood in the stool. An early stage colorectal cancer oftentimes has no symptoms. Patients feel totally fine, and you would never kind of know something's going on. That's why we promote. Yeah, that's why we promote often and frequent colonoscopy.
And does it cause weakness or pain or weight loss?
So it can, but usually only at the later stage. Colorectal cancer is a very slow growing cancer. So it's usually years into having the cancer and kind of a pretty distant state that you would start having pain or weight loss. So many patients will come to me and say that they feel totally fine, that this is an unnecessary thing, but we're not doing this to look for a cancer. We're doing this to prevent cancer. And many times in early stage cancer, you won't even feel anything.
Well, that's good. And we've got to go on a break. We're talking to Dr. Andrew Boxer, MD, gastroenterologist, board certified, and he's also in internal medicine and he's a graduate of Robert Wood Johnson Medical School, and he's a partner in Gastroenterology Associates of New Jersey. And we'll be right back with Dr. Andrew Boxer. Welcome back. We're talking to Dr. Andrew Boxer, MD, gastroenterologist is his specialty. He's board certified in internal medicine and gastroenterology. He is a partner in Gastroenterology Associates of New Jersey. Doctor, does smoking and drinking alcohol increase the risk of colon cancer? And what about eating red meats, which I hear is a no-no?
Yeah, so that's excellent questions. And certainly we have some answers to some of this. And some of this kind of the studies just aren't quite there yet. So there's no question about it that smoking will increase your risk of almost any cancer out there, including colorectal cancer. So the more you smoke, the more at risk you're going to be for colorectal cancer. Alcohol can certainly play into some GI cancers, but probably not so much into colorectal cancer. Food has been a pretty hot topic of discussion for the last few years. And it's a little confusing. What I mean by that is there are certain foods that have been implicated, specifically red meat, deli meats, processed meats, and then processed foods. And each one kind of a little bit differently. There have been certainly studies that have shown all of these may increase your risk of colorectal cancer, and some studies that say maybe that's not the case. But the thing that's a little confusing is obesity will actually increase your risk of colorectal cancer. For the most part, people who are eating a lot of processed food, red meats, and kind of deli meats, when compared to vegetarians, usually, not always, but usually, at least in the studies, they're more overweight, obese. So we're not sure if it's the obesity or if it's actual foods that are doing it. There has been some great studies recently out of Europe that have shown patients who have a large portion of their diet who are eating a lot of processed foods, so things like potato chips, French fries, fried fatty foods, do increase colorectal cancer. So ultimately, the answer is we're not exactly sure, but it's not going to hurt to eat healthy. It's going to probably be a better thing to do, to eat a lot of fresh fruits and vegetables.
Good advice. And at what age should a person undergo screening for colorectal and colon cancer? And what is the difference between colon and colorectal cancer?
Yeah, so colorectal cancer or colon cancer, rectal cancer, it's just a lot of nomenclature. It's just a lot of kind of the words that we're giving it. The colon is the same thing as the large intestines. In the very end of the colon, that part that's kind of stores the stool right before it comes out, that's the rectum. So when we talk about colorectal cancer, that's talking about the whole large intestine. If we say rectal cancer, we're talking just kind of the very end. We're being very specific. The cancer's at the very end. And if we say colon cancer, kind of that could really kind of just be just a short way of saying colorectal cancer, and mean that it's colon cancer not in the rectum. In the end, it's kind of a lot of nomenclature. For screening, we recommend everyone age 45 and above to get it. Age 40 or 10 years before anyone who has a first-degree family relative. And certainly if people have, some people are out there with some odd genetic syndromes that could increase risk, we would start doing that at kind of very young ages.
And are the symptoms for colorectal cancer different than the symptoms of colon cancer?
So sometimes. So rectal cancer sometimes could present a little bit differently, and just because the rectum's at the very end of the colon near the anus, and it's kind of closer to kind of being deep inside the body. So certainly, if it's there, kind of you might see bleeding a little bit more. Certainly, you might have some more discomfort. It's possible to have kind of some more constipation, but not necessarily.
Right. And can chronic inflammatory diseases of the colon, such as ulcerative colitis and Crohn's disease, increase the risk of colon cancer? And what can be done about this?
Absolutely. So Crohn's disease and ulcerative colitis are what we call inflammatory bowel disease. Inflammatory bowel disease, as you said, are chronic inflammatory conditions, autoimmune conditions that inflame the large intestine. And when you have long-standing chronic inflammation, that could create something that we call dysplasia. Dysplasia are precancerous cells, and then if they're left there and those stay inflamed, that could kind of one day turn into cancer. So a few things. So the lowest amount of inflammation for kind of the longest period of time, or keeping inflammation kind of at bay, is going to be the best thing at preventing cancer. Somebody who has chronic IBD, inflammatory bowel disease, that's untreated, is going to be way higher risk than somebody who's in remission, who's properly treated. Standard of care for these patients to be getting colonoscopy very frequently, usually once a year, once every other year, depending on how things are looking, usually starting at a pretty young age. And we do kind of multiple biopsies throughout to look for these precancerous areas of dysplasia.
Right. And Dr. Boxer, what is the preferred colonoscopy? Is there one? And what are the treatments for colon or colorectal cancer? What do they entail?
Yeah. So when we talk about colorectal screening, there are many different ways to do screening. And ultimately, the best screening test is the test that the patient's willing to do. There kind of, when we look back kind of at the infancy of colorectal screening, there was what we call a fecal occult blood test, and that's a stool test looking for blood. If that came back positive, that would alert us that something could be going on, and we would kind of take measure at that. Something kind of a step ahead of that was something called FIT testing, essentially looking for blood again. Many years ago, a hot topic was virtual colonoscopies. Essentially, it's a CAT scan that's fallen out of favor for many reasons, looking to see if there are any growths in the colon. Nowadays, there's kind of many commercial tests. The big one that a lot of people talk about, something called a Cologuard test, which is a stool test looking for stool DNA and also looking for blood. And there's something kind of in research that will probably be out pretty soon, something called a liquid biopsy, which is going to be a blood test, which is going to hopefully tell you if you have polyps or cancer. And then the gold standard out there is a colonoscopy. A colonoscopy is when we give that laxative, we give you sedation to make sure you're sleeping. We take a camera and really see what's going on. It's the only test out there which is preventative. That's the only test out there where you could actually go and look for polyps and remove them. Every test that we spoke about beforehand will just kind of tell us kind of the risk if they think that if the test thinks that there's actually something going on or not. Treatment for colorectal cancer is kind of based on staging. It can be a combination of both radiation, chemotherapy, and surgery, depending on what's going on.
Well, that's great advice. We're talking to Dr. Andrew Boxer, MD, gastroenterologist, is a specialties board certified in internal medicine and gastroenterology, and he's a partner in Gastroenterology Associates of New Jersey. I'm Jessie Frees. We'll be right back with Dr. Andrew Boxer. Welcome back. We're talking to Dr. Andrew Boxer, MD, gastroenterologist, as his specialty board certified in internal medicine and gastroenterology. And Dr. Boxer, we understand that if colon cancer is one of the more treatable cancers if you catch it early, what can we do to minimize our risk?
Absolutely. So colorectal cancer, when caught early, is treatable, beatable, and kind of the most important thing is preventable. So our goal is to kind of be able to find these polyps way before cancer ever develops. The lucky thing with polyps and colorectal cancer is it's usually slow growing. So there's great response rates to surgery, chemotherapy, and then when it's found in the rectum, radiation can sometimes be used. So the best thing to do is frequent colonoscopy. If we find it early, we're able to many times beat it. And then if you find it before it even happens, we could prevent it. So colon polyps are common. Probably about 50% of Americans over age 45 have precancerous polyps. One day, about 5% of Americans will develop colorectal cancer. So our goal is to find these before that could ever happen.
And I understand, Dr. Boxer, that gastroenterologist is a highly specialized physician in the management of diseases of the gastrointestinal tract, including digestive problems. So maybe we could ask you a few questions on that. If you suffer from persistent heartburn 2 or more days a week, could you have acid reflux disease? Will you discuss that?
Of course. So absolutely. So acid reflux disease, or a lot of times we'll call it GERD, gastroesophageal reflux disease, is a very common thing. There's a lot of things that can cause this to happen. Essentially, it's when stomach acid or stomach contents comes up and bathes the esophagus. Normally, there's a sphincter or muscle that controls the barrier between the esophagus and stomach. So when you eat, food will go through your mouth into the esophagus, into the stomach, and it's usually tight, not letting food come up. So depending on certain things, different medicines, weaknesses in that muscle, different hernias, kind of a host of different factors. When you eat food, type of food you eat, that can affect kind of reflux and acid coming up.
And does heartburn range in severity? When is it dangerous? Let's go over the possible signs of heartburn that could be mistaken for a heart attack.
Of course. So heartburn is dangerous. It's a silly thing to say, but heartburn's dangerous only kind of when it's dangerous. It could be annoying. It could be feeling like a heart attack. So sometimes it could actually be very, very difficult to tell the difference. So if you're having kind of crushing chest pain, or someone who's at risk, so of the right age range or proper risk factors, certainly should have a immediate evaluation with a medical practitioner that likely would include things like different blood work, EKG, chest x-ray, make sure there's not something devastating like a heart attack going on. And heartburn's dangerous usually when it's chronic, usually when it's going on for a long period of time. So chronic irritation or bathing of the esophagus and stomach acid can create something called Barrett's esophagus, and that could become precancers for esophageal cancer. The other thing that we worry about is acid reflux sometimes might be a sign that something else is going on. So when I talk about the GI tract, I talk about it being kind of a long hose or like a kitchen sink. So when you eat, food will go through your mouth into your esophagus, your stomach, your small intestines, colon, and then out. So if there's something going on like a blockage or a really big ulcer not letting things come out of the stomach, it's got to go somewhere. So it's going to back up and you might be having a lot of acid reflux. So if there's alert signs and symptoms going on, if you're vomiting blood or blood in your stool, if you're having weight loss, trouble swallowing, if you were feeling fine for many years and all of a sudden things just all of a sudden got really bad, or if you take some over-the-counter medicine for a week or two, it's not working, or you need to take it for more than a week or two, or if any of these things, if you have new digestive problems over age 65, these would be of concern to me, and they would trigger us to really kind of take a look, usually with something like an endoscopy.
Great advice. And let's go to GERD. What is gastroesophageal reflux disease, or GERD? Would you explain that?
So gastroesophageal reflux disease, or GERD, it's kind of the simple term that we give for heartburn or reflux. It's actually a pretty, nomenclature here could be very complicated. So patients could certainly have different types of reflux, some of them being acid and some of them being non-acid. There's a whole bunch of different ways that we could measure this, usually with different probes or different instruments that we would put in the lower esophagus, usually for a 24-hour period, to really measure, to see what's going on, see if there's actually reflux coming up, things coming up into the esophagus, and to measure the pH or the acidity of it.
And how often should one become alarmed if this is ongoing, these symptoms?
Yeah, so if these symptoms are going on for more than 2 weeks, come see a professional. The other thing to say is a lot of patients come to see me and they say that I have tried some over-the-counters, but the over-the-counters say don't use for more than 2 weeks. And I think that's good advice typically. Many times these medicines are very safe to use chronically and you could use them for a long time. But if things are going on for more than 2 weeks, it's time to come see a specialist.
And I only have a minute left, but how is GERD diagnosed? And do we know what causes GERD?
Absolutely. So the diagnosis of GERD could be made many, many different ways. Sometimes we could do it through imaging tests, sometimes through history alone, so just talking to patients. We could do it with pH monitoring, kind of the ways that we were talking about, putting a probe into the esophagus. Endoscopy could look. So there's many, many ways that it could happen, many ways that we could measure it or diagnose it. And it happens for many reasons. So eating late at night can do it, eating spicy food, different medicines can cause it. It's kind of really a host of different things that can do it. Could probably talk literally for hours on the causes of reflux.
Well, you are a great one to talk to. Our time has come to a close, and we thank you for a most educational review on colon cancer and digestive issues. Dr. Andrew Boxer, partner in Gastroenterology Associates of New Jersey. How can someone reach you?
So the best way to get me would be through our website, actually. So GANJ, GANJ, LLC.com. We're a big GI group up in northern New Jersey. We have over 40 practitioners. You'll certainly find kind of me on there. And we're really an excellent group with really, really specialized practitioners within the field of gastroenterology. So definitely come see us for all of your digestive needs.
Well, we certainly will. Dr. Andrew Boxer, partner in Gastroenterology Associates of New Jersey. Thank you again for joining us on Ask the Expert.
Thank you for having me. I appreciate it.
And it's been a pleasure. Stay tuned for Julie Briggs and her riveting political roundtable coming up next. Don't miss it. I'm Jessie Frees. Have a good day. Good day.